Greetings. I am Harpreet Singh Bajaj, and on behalf of my co-authors, Dr. Ali Imran, Dr. Jinnah Agarwal, and Dr. Stuart Ross, it is my pleasure to present targets for glycemic control in Diabetes Canada's 2018 Clinical Practice Guidelines. Here's a summary of the key changes between 2018 from the previous 2013 guidelines. The first point is around addition of a new target category of functionally dependent for the relaxed target of 7.1 to 8% A1C. Further, for those individuals who are not meeting the target A1C of less than equal to 7%, a lower fasting plasma glucose and postprandial glucose targets are recommended. Finally, the key change is that there is strengthening of the recommendation for the more intensive A1C control, who this applies to. So less than equal to 6.5% A1C target is recommended for those people living with type 2 diabetes who have a low risk of hypoglycemia based on their class of antihyperglycemic agents and person level characteristics. So here's a quick targets checklist. There are three target levels. An A1C of less than equal to 7% applies to most people with diabetes. An A1C less than equal to 6.5% applies to some people with type 2 diabetes. And an A1C of 7.1 to 8.5% or a relaxed target is reserved for some people with specific features. Let's clarify these target categories further in the new A1C targets figure for the 2018 targets chapter. Less than equal to 7% A1C is recommended for most adults with type 1 or type 2 diabetes. Less than equal to 6.5% is a recommended target for people with type 2 diabetes to reduce their risk of nephropathy and retinopathy if they are considered to be at low risk of hypoglycemia, which is based on the class of antihyperglycemic medications and person level characteristics. Highlighted in yellow is a more relaxed target of 7.1 to 8.5% A1C, which is reserved for certain individuals. For those who have functional dependency, an A1C target of 7.1 to 8.0% is recommended, or even more relaxed target of 7.1 to 8.5% is recommended for those who have recurrent severe hypoglycemia or have hypoglycemia unawareness. Also, this relaxed target applies to those with limited life expectancy, frail, or people with dementia. It is recommended that even within these relaxed target categories, we should try to avoid higher A1C levels to minimize the risk of symptomatic hyperglycemia and acute and chronic complications of hyperglycemia. Further, at the end of life, A1C measurement is not recommended. It is, however, recommended to avoid symptomatic hyperglycemia and any instance of hypoglycemia. This table highlights the achievement of fasting or preprandial glucose levels or 2-hour postprandial glucose targets to achieve an A1C of less than equal to 7%. For most patients, just like in 2013 guidelines, the recommendation is for fasting glucose of 4 to 7 and 2-hour postprandial glucose of 5 to 10 millimoles per liter. If, however, with these fasting and postprandial glucose targets, an A1C of less than equal to 7% is not achieved, a more intensive fasting plasma glucose level of 4 to 5.5 millimoles per liter and a 2-hour postprandial glucose level target of 5 to 8 millimoles per liter is recommended. This is a new table that has been added to the 2018 chapter. This shows the correlation between A1C and estimated mean glucose values on fingerstick glucose, continuous glucose monitoring, or flash monitoring devices. As we know that A1C value is not equal to the estimated mean glucose in millimoles per liter, but there is rather a formula to calculate this. Hence, this table simplifies that equation. This table can be utilized to achieve target categories. So for a target category of less than 6.5% A1C, or 5.5 to 6.5% on A1C, would correlate to an estimated mean glucose of 6.2 to 7.7 millimoles per liter. On the other hand, at the uh, end of the table on the last column, an A1C of 8 to 8.5% would correlate to estimated mean glucose of 10.2 to 10.9 millimoles per liter. Now let's take a look at the evidence that was utilized behind making all these recommendations. Let's start with an A1C target of less than or equal to 7%, which is recommended for all people with type 1 or type 2 diabetes. This slide shows the landmark DCCT trial, which was published in New England Journal of Medicine in 1993. This 6.5-year duration of the trial randomized about 1,400 people with type 1 diabetes to an intensive glycemic control strategy with 3 or more injections per day or an insulin pump, and compared it to conventional strategy with 1 to 2 injections of insulin per day. As is highlighted with the arrow, in the intensive glucose arm, an A1C of 7% was achieved within the first year and maintained throughout the trial duration, whereas for the conventional arm, an A1C around 9% was achieved and maintained. These two graphs represent the reduction in microvascular complication, specifically retinopathy, in the DCCT trial. In the primary prevention subgroup, that is the subgroup who did not have retinopathy at baseline, there was a 76% relative risk reduction in favor of the intensive glycemic control arm, whereas the conventional arm had a higher rate of retinopathy. In the secondary intervention subgroup, that is the subgroup which had previous retinopathy at baseline, there was a relative risk reduction of retinopathy by 54%. Both of these were significant. Albuminuria, another microvascular complication, was similarly reduced both in the primary prevention subgroup with a relative risk reduction of 34%, and in the secondary intervention subgroup with a relative risk reduction between 43 and 56% for albuminuria, favoring the intensive control arm. And finally, the third microvascular complication of neuropathy was reduced in the intensive control arm of DCCT, as is depicted in this bar graph. These changes in neurological examination, autonomic nerve study, as well as nerve conduction study were statistically significant. It should be noted that cardiovascular endpoints were not significantly reduced in the DCCT, nor was there a significant change in mortality. On the flip side, there was a 2 to 3-fold increase in severe hypoglycemia in the intensive control arm of DCCT. The DCCT trial ended at 6.5 years and was further followed up observationally for an additional 10 years. During this time period, there was a 57% relative risk reduction of cardiovascular endpoints combined, called the MACE endpoint, which includes non-fatal myocardial infarction, stroke, or cardiovascular death. And this was statistically significant in favor of the intensive arm. And more recently, a 30-year follow-up of the DCCT and EDIC study has been published in JAMA in 2015, which shows a relative risk reduction of 33% for all-cause mortality in this long term of follow-up. These two changes over the EDIC follow-up study suggest a legacy effect for early glycemic control in type 1 diabetes, which within the trial period reduce microvascular complications, and then over the follow-up reduce macrovascular complications as well as all-cause mortality. UKPDS is the landmark trial based on which the A1C target of less than equal to 7% is recommended for people with type 2 diabetes. As we know, UKPDS randomized almost 4,000 people with recent onset type 2 diabetes to an intensive control strategy where the goal was to achieve a fasting glucose level of less than 6 millimoles per liter versus a conventional strategy. In the intensive glycemic control arm of UKPDS, the mean A1C was 7% compared to the 7.9% in the conventional arm. This table highlights the outcomes of UKPDS. In 1997, which is the end of the trial period, there was a relative risk reduction of 12% for any diabetes-related endpoint, which was statistically significant. This was largely driven by microvascular disease relative risk reduction of 25%. The myocardial infarction endpoint was reduced 16%. However, this did not meet the statistical significance level of p-value of 0.05 and was slightly higher than that. When this population was followed, just like in DCCT, with an observational study, the results presented here at 2007 are from a 20-year follow-up of UKPDS, which showed a continued any diabetes-related endpoint reduction of 9%. Microvascular disease reduction remained stable at around 24%. Myocardial infarction at 20 years was reduced, and this time it was statistically significant, remaining around the 15% mark, whereas there was a reduction of all-cause mortality that emerged with a relative risk reduction of 13% for death, which was statistically significant as well. So the less than equal to 7% A1C targets come from the landmark DCCT and UKPDS trials with their long-term follow-ups. Let's turn our attention next to the next A1C target category of less than equal to 6.5%, which is recommended for people in early type 2 diabetes, balancing against the risk of hypoglycemia. Further from UKPDS in people with type 2 diabetes, there have been a few additional trials looking at more intensive glycemic control than the 7% achieved in the UKPDS. The less than 6.5% A1C target is derived from the ADVANCE trial, which was published in the New England Journal of Medicine in 2008. The intensive glycemic control arm goal in the ADVANCE trial was to achieve an A1C of less than equal to 6.5% versus a standard glycemic control strategy. This graph shows the glucose control achieved in the ADVANCE trial in the two arms. So as you can see, over the 5-year trial period, there was a 6.5% mean A1C in the intensive control arm compared to a 7.3% mean A1C in the standard control arm. Because of this glycemic control difference in the advanced trial, the intensive control arm had a reduction in the primary microvascular combined outcome of new or worsening nephropathy and retinopathy with a relative risk reduction of 14%, so a hazard ratio of 0.86, which was statistically significant. This was primarily driven by nephropathy outcome, which was reduced by 21%, so a hazard ratio of 0.79, which was statistically significant as well. On the flip side, severe hypoglycemia, although it was uncommon, was increased in the intensive control arm with a hazard ratio of 1.86. Hence, the targets chapter for the 2018 Diabetes Canada CPGs recommend that an A1C level target of less than equal to 6.5% should be tried to be achieved in people who have low risk of hypoglycemia. Hence, the hypoglycemia risk should be balanced against the benefit of microvascular disease risk reduction that was observed in the advanced trial. Finally, let's turn our attention to the third category of 7.1 to 8.5% for A1C for certain individuals. Remember, this relaxed target is for certain individuals who have functional dependency, then the target should be 7.1 to 8%, or those who have recurrent hypoglycemia, which is severe, or with hypoglycemia unawareness, the target should be further relaxed to 7.1 to 8.5%. Similar targets of 7.1 to 8.5% is recommended for people with limited life expectancy or for frailty or those with dementia. For further information, please refer to the Diabetes in Older People chapter in the 2018 Diabetes Canada CPGs. I'm just going to highlight a clinical frailty scale that is used for the relaxed targets. As you can see, this frailty scale has images and text. Images are easier to follow. What depicts mildly frail is different from what depicts moderately frail or severely frail, as well as very severely frail. So these images should be kept in mind when choosing the relaxed targets. That gets us to the recommendations from this targets chapter. The first recommendation is that glycemic targets should continue to be individualized. In most people with type 1 or type 2 diabetes, an A1C target of less than equal to 7% should be used to reduce the risk of microvascular complications, as is clear from DCCT as well as UKPDS trials. And then if A1C of less than equal to 7% is implemented early in the course of disease and people are followed for longer duration of diabetes, cardiovascular complications can be reduced, which is clear from the follow-up studies of DCCT and UKPDS. The third recommendation is in people with type 2 diabetes, a more intensive A1C target of less than equal to 6.5% may be useful to reduce the risk of nephropathy and retinopathy if they are assessed to be at low risk of hypoglycemia, which is based on the class of anti-hypoglycemic medications that are utilized, as well as personal level characteristics. Finally, the A1C target relaxed to 7.1 to 8.5% may be considered in people with diabetes with the goals of avoiding hypoglycemia in these people, as well as the possibility of overtreatment related to antihyperglycemic therapy. This includes the functionally dependent category, where the targeted recommendation is 7.1 to 8% for A1C, or those with history of recurrent severe hypoglycemia, especially if this is accompanied by hypoglycemia unawareness. The target A1C is 7.1 to 8.5%. The same target applies to those with limited life expectancy, those who are considered frail, or with dementia. At end of life, A1C measurement is not recommended. The recommendation is to avoid symptomatic hyperglycemia and any instance of hypoglycemia. The final recommendation deals with fasting plasma glucose and postprandial glucose targets. In order to achieve an A1C of less than or equal to 7% for majority of the people with type 1 or type 2 diabetes, FPG or preprandial glucose target of 4 to 7 millimoles per liter, and a 2-hour postprandial glucose target of 5 to 10 millimoles per liter is recommended. On the other hand, if this is not enough to achieve an A1C target of less than or equal to 7%, then further fasting plasma glucose target lowering to 4 to 5.5 millimoles per liter and or postprandial glucose lowering to 5 to 8 millimoles per liter may be considered, but this must be balanced against the risk of hypoglycemia. Summarizing the key messages in this chapter, optimal glycemic control remains fundamental to the management of diabetes. Both the fasting and postprandial plasma glucose levels correlate with the risk of complications and contribute to the measured A1C level. Glycemic targets should be individualized, and this individualization should be based on a host of person-level characteristics. The 2018 chapter also includes key messages for people who are living with diabetes. These include that people should try to keep their blood glucose level as close to their individual target range as possible to try and prevent or delay complications of diabetes. The individual target ranges for blood glucose levels or for A1C vary depending on a person's age, medical conditions, and other risk factors, and these individual target ranges should be determined in conjunction with their diabetes healthcare team. The full Diabetes Canada 2018 clinical practice guideline can be downloaded, as well as you can visualize and use interactive tools and other useful resources on the website guidelines.diabetes.ca. The information is also available to download as an app on the App Store or on Android devices. For further information, here's the contact information for Diabetes Canada Clinical Practice Guidelines. Thank you for listening.